I'm going to have the opportunity to introduce Dr. Bob HIlt, and this is our final lecture of the academic year for our workforce initiative, and he's going to be presenting on community consultation services and the PAL line, which I know I hear about in just about every venue that I talk with people. They're like, oh, have you heard of the PAL line? Do you know the PAL line? So I think it's just going to be really exciting to hear about where we are with the PAL development, and he's going to share with us about that. So Dr. Hilt's an associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington and Seattle Children's Hospital. He is a general pediatrician who is trained at the University of Iowa and was trained as an adult and child psychiatrist at the University of Massachusetts. He's been a primary care pediatrician, pediatric hospitalist before his current career as a child psychiatrist. And he's program director of the Partnership Access Line, which is a mental health consultation service for primary care physicians and providers in both Wyoming and Washington State. There's lots of other things on this list that make a very impressive resume, but I think that probably without further ado,
I'll just get started.
Let's get started. Thank you so much for being here.
So let me click to. Okay, we're all set. So yeah, we've been doing this PAL-ish stuff for a few years now, so this is going to be a general overview of what we've been doing and some of the things we've learned in the process. I always start talks with disclosures. I work for the University of Washington in addition to Seattle Children's. I've received some consulting fees for Xerox Care Quality Solutions in Armstrong Teasdale. There's research funding from CMS and HRSA, and there's a book that's come out from American Psychiatric Association Publishing. So my list got longer. It used to be nothing. So where do we start? You know, why do we have PAL? Primary care providers do lots and lots of mental health care work. If you look at the chief complaints, the reason you're there today, of those walking in the primary care office, the data has said about 20% of what walks in the door is a behavioral health chief complaint. Now that's a little bit old numbers. When I talk to providers now, they said, it's more than 20%. But we had actually done a survey when we were getting the PAL program started to ask about what proportion of mental health they saw, and they told us 20%, just like the other national numbers at the time. If you say, well, why are you here today? You know, they've had a tummy ache, they've had headache problems for some time, but that's been going on for months. Why are you here in the office today? Behavioral health is a corollary concern in nearly half the other appointments. They deliver about half of all mental disorder treatment in our country, and they prescribe the majority of psychotropic medications. So when we're talking about child mental health, primary care is a big, big player, whether they wanted to or not. And it's partly because the mental health problems are really common. Statistically, about 20% of all kids have mental health disorders, and very few of them get traditional mental health treatment. So they go to the primary care, they go to the school, they get some kind of help, but they don't necessarily walk in the door of a mental health treatment center. And that has to do with insurance and who's being paid for and the availability based on that resource, and actually just having the people to do it. There's some great things about being a primary care provider that I lost as soon as I switched hats from being primary care to being a psychiatrist or a shrink. You know, we have negative terms about mental health people. Primary care generally doesn't have stigma. People inherently trust their primary care providers. They've been familiar with the family for years when things were doing well before they don't go well. They're generally more accessible in where they are. There's generally not insurance restrictions, although hopefully in the future insurance restrictions aren't going to be such a big deal. Right now they still are. And if you go to the primary care doc, you're going to get some kind of intervention by having gone there, some kind of feedback, some kind of advice. And if the doc says, this is a big problem, I think you should see a mental health provider, very often they don't go and they end up receiving nothing. What it's like to be a primary care provider is very different than being in mental health. So 25 to 30 patients a day. I used to see that many in 6 scheduled hours with beginning of the day and lunchtime where I'd run to the hospital. So when you had mental health come up, it was there's this part of you that's like, oh, that's going to throw my schedule. You only have about 15 minutes per patient on average. And the hand on the door, oh, by the way, questions is often where that comes up. So it's a challenge as a pediatric primary care provider to handle the mental health things competently, efficiently, and not feel like it's a burden. Clearly, the families are looking for help. Do the primary care docs want to do it? And I say, tongue-in-cheek, no. As a rule, generally they're not saying, wow, I became a primary care provider because I wanted to be a mental health provider. But you always want to help the person who's in front of you that day. So that, I could say, is universal. Can you do something useful in 15 minutes? I say you can. And you can't do in 15 minutes what a mental health provider will spend an hour doing. It's not quite the same thing. But, before you see somebody, you could have them pre-screened with a validated rating scale to give you a little bit of a clue of what might be going on, or break up your appointment partway through. It's like, you're raising some issues. Can you work on this? I'm going to pop in and I'll come back. So there's a way to supplement your history gathering time with tools. You can identify what the leading concern is. You can talk about safety. If they're depressed or suicidal, you can bring that up and address it. You can get a sense of what's likely going on. You're not going to know for sure what's going on in a 15-minute appointment. And you can recommend a next step. And all that's very useful. So there's a lot you can do in just 15 minutes. If you, as a primary care provider, just another dynamic to consider, become known as the person who does mental health, guess what you get? I actually discovered this myself in a group where I was just seeing tons of ADHD evals. It seemed like a third of my day was just new ADHD evals. And I was like, why is it going? And I talked to the people on my front desk. They said, well, didn't you know that you're the only one in the group accepting new ADHD patients? I did not know that. I'm in a group with 7 other people. So they're all coming to me. So I was the one who was willing to. So if you get known in the community as the person who does mental health, or known within your group as the person who's willing to do mental health, you tend to get all that stuff shoved your way. And so that's a dynamic that comes up with going into a learning collaborative to say, oh, I've really learned how to do this mental health stuff. Now you have a flag on your head. You're the mental health guy or girl or whatever. Personnel, there are just not enough mental health providers across the board. That ends up being particularly acute for child psychiatry. It's not unique to child psychiatry, also true for a skilled child therapist. The numbers work out. If you say how many kids have serious emotional disturbance, how many providers do we have in the state of Washington, there's 1,100 kids with serious emotional disturbance for every child psychiatrist. In Wyoming, another state we work with, there's one for every 1,500 kids with serious emotional disturbance. At best, a child psychiatrist is working full-time outpatient, maybe have a couple hundred that are under active management. So the numbers just don't work, just to highlight the kind of challenges we have. This is a map of where child psychiatrists are located, both nationally and within the state of Washington. Everything that's dark blue represents a county where there's no one. So you can get a sense that, here's the I-5 corridor in Spokane, where people tend to be located. And it's not a surprise, you probably guessed that as well, and a little bit in Yakima. But nationally, there's huge swaths of the country where there's nobody. There's been an effort to train more child psychiatrists, recognizing that's the case, but it's barely keeping up with people who are leaving the field through retirement and the like. So that's not solving the situation. And even if we had enough, like I mentioned before, a lot of families won't go to the mental health provider. And so they end up getting nothing. If they refuse to see a child psychiatrist, they'll get no care. There's about a 40% no-show rate when the primary care doc says, go to the mental health centers. They won't go for a single appointment. And if they go for one appointment, they're often not going for multiple appointments. So there's this challenge of referral to care and what you actually get. So the idea with PAL was taking all that sort of into account in the background is to try to leverage the expertise to help primary care providers manage more of these scenarios and really try to get the mental health specialists more and more involved with the more complicated cases. So there's a phrase about practicing at the top of your license. So if every child psychiatrist had a boutique practice where they just take care of the worried well, you're really not serving the public health care needs. If you can help primary care to take care of the mild to moderates as best they can, that's taking a lot of pressure off the system, and those who have the skills to handle the moderate to severes are handling the moderate to severes, not the other way around. So this is something that we think was going to happen with the Affordable Care Act, but that remains to be seen. So if you help primary care, what are your options? You can offer education, you can do lectures, you can provide consultation. By the way, what we're doing right now is probably the least effective way to learn something. Adult learning models say that if you sit in a room and somebody's talking to you, tends to, the likelihood that you're going to enact what you've heard is lower than if you're actively participating in some way. It's the core of mental health training and doctor training is we learn with our own patients ultimately. We practice, we do things, we talk to others, and then we try changing what we do. So we can consult with primary care. There can be elective consultations and frankly mandatory consultations where somebody says you must talk to another person. You can have care managers who can collaborate. You can have integrated mental health clinicians who are off-site but linked and well communicating, or on-site co-located. And co-location is not integration. Co-location is sometimes parallel play, where I just do my little thing, you do your thing, and it's not like we don't even work together. And then there's traditional mental health care. We always are going to need traditional, especially mental health services that we've done so much work on to help the significantly ill people. So that has to be part of the system. Telemedicine is often touted as, well, we'll just provide telemedicine. And it's a great access tool, but I talk about it changing the shape of the box. You can only see just so many kids. And if if I'm based in Seattle, I can see a bunch of kids in Seattle, but maybe I'll see a few less in Seattle and see a few in a rural area. But you're not overall increasing system capacity. You're just borrowing from Peter to pay Paul. So consults over the phone were always attractive to me. While I was a general practicing pediatrician here in Washington, I never once got a child psychiatrist on the phone to talk about any of the kids I was working with, and that's not for lack of trying. I never got any of my kids in to see a child psychiatrist. So I was managing at Harrison Memorial kids who had made serious suicide attempts and the like. I could not get them in an inpatient unit. I was it. So even within Washington State, that was my experience. While I was going through training, there was a program that was starting out a phone-based consult service, and I thought, oh, I'll do my training at a place that's experimenting with this because I think we should be available by phone. So I got to watch that develop in Massachusetts. The idea of a phone is it's really low technology. There's no technology barrier to this. Phones are ancient. You're only providing assistance when the primary care provider is asking for assistance, and you can have teachable moments on the provider's patient. So at the moment they say, what do I do? How do I handle this? Okay, I'm really receptive to that idea that I'm going to then enact immediately. And you can match level to PCC engagement. So there's some providers that's like, none of my patients have mental health problems. There are no mental health problems. There's hear no evil, see no evil. It's hard to move them. Those that are willing to try to do some things can use a little bit of help. Those are really, this is really important for my patient population, can reach out for help all the time. And it doesn't require putting a flag on your head to say, I'm now the local mental health expert. So what Massachusetts did is they had pretty generous funding. They set up a system with 6 different regions in that small state, each one with its own academic medical center and its own child psychiatry training program, and provided a separate hotline and staffing and social work and admin time, and there were 6 separate systems working in that state, available in business hours, and they could go around, because they're very small state and very local, they could go around and have office greet and meets with the providers in their area. When I came to Washington in 2006, I thought, hey, we should do something like that. You know, I had experienced this as a real problem, and thought we should have something like that here. And it led to a lot of conversations with a lot of different people. This is not an easy proposition to get something off the ground. So legislators, hospital representative, community leaders, state pediatricians were really key. Leaders in like Dr. Troopin and Evidence Based Practice Institute, my chair, Brian King, a lot of different people were saying, yeah, that makes sense. So how would we do something like that? And the timing of the discussion was also helpful because it was right before the recession. So the state actually thought, hey, we could try some things. We actually turned to the providers in the state, just let's document how bad is it, and asked primary care providers in the state, you know, can you meet the needs of kids with psychiatric problems? And for Medicaid patients, can you access a child psychiatrist in any way, shape, or form when one's needed? And 20% of the time they said, yeah, we could do that. But it matched what we thought. So there was a bill that was passed, contract signed. We'd only started in 2008. Initially, we planned for both a learning collaborative and for what became the partnership access line. And there's complicated stories as to why both were planned. The learning collaborative process was discontinued because of, to me, not unexpected enrollment challenges. Because again, if you become, you know, in your community, the one or one of 2 people who said, I'm the person who now knows how to do mental health, you know what happens. So we ended up doing what became PAL. We started in a small region and then expanded statewide. And a few years later, state of Wyoming reached out to us and said, hey, could you do that for us too? General with advocacy in getting a thing like that started, good ideas alone are clearly not enough. A lot of people have to, who know how things work, who know how to get things done, have to get on board. So you have to have administratively and politically savvy people to help a process like that alone. And as a psychiatrist, I'm much less trusted, frankly, if I go to legislators or other people than if I'm a pediatrician. It's the reality of our world. So if only mental health people are asking for something to happen, it's not as powerful as if community members are asking for something to happen or primary care providers are asking for something to happen. And you never get exactly what you ask for. You got to compromise. Roughly speaking, we are very different than Massachusetts, big surprise. It's a very different state. That's geographically to scale. And we're funded way less per capita to do what we're doing than Massachusetts is. So we're a very different, you know, yeah, PAP was our model, but we got to do something different. So some of the things we're doing is holding CME education courses. Rather than being able to drop by every single provider's office and greet them and shake their hands, we give an event for them to come to us, in essence. Created something that would be really attractive for them, this care guide, that they could use, whether or not they're calling us, frankly, to help be another reminder to use us when things don't go well. And we put it for free on the web. Actually, that care guide started as the fidelity manual, because I was the first consultant for PAL, and then when we knew we were going to be adding other people, wanted to make sure people were having the same message. And so started off writing a fidelity guide and thought, well, shoot, as long as I'm writing this thing, might as well direct it to the primary care providers. So that's how the care guide evolved. So some of the things we put in there is logic diagrams of, you know, if somebody is you're thinking about an ADHD diagnosis, what you might need to consider, what are the key diagnostic points, and if you're going to recommend treatment, what kinds of treatments and why would be appropriate, and try to make it very easy, I got this, for primary care providers. You can make this very complicated or boil it down to what you got to knows, and that's what it is. Boil it down to what you got to know. Free rating scales that they could use that have been validated, handouts about, like if somebody has an anxiety problem, here's some books, here's some videos, here's some phone numbers to call. The processes during business hours, 8 to 5, Monday through Friday, all the primary care providers in the state can call and usually immediately get connected to a child psychiatrist to talk about whatever's going on with any of their patients. And although we are getting our money to do this through the Medicaid division, the healthcare authority, this is insurance blind for that initial contact. We have another layer of service that is Medicaid specific that we can offer a consult appointment when that makes sense per the discussion, and that's for the Medicaid clients. The principle is anything you learn on any of the patients that you're calling about, you're going to generalize to the next person you see. And so this is an overall raise all the boats effort. Molly, who's here today, is a social worker who works with us in helping to identify when somebody needs psychosocial intervention services in their community, what's the best way to connect to that? What number should we call? Who's likely to be available and the like. We also, this is unusually nationally because I know there's a number of other states doing programs like this. We actually write down what we said and give it to the provider for their record keeping. There are other programs that have been doing consult access that have said, no, this is just a general education service. We're not giving patient-specific information. And they're completely ignoring the fact that any primary care provider worth their salt who's talked to a child psychiatrist is writing down exactly what they said to do in the patient's chart. So it seems kind of silly. But we do this for making sure if we've recommended something that it's clear and not misunderstood over the phone and can be referenced later when something didn't go right or it worked for a while and then it didn't work. What else did we say to do if then? So when we do our consults, this is what I recommend now. If that doesn't work or is not available, then you could try this and this. So we try to provide enough advice like that. Some of the things we learned in the process, getting any primary care provider to do something, well, any doctor, to do something different than what they've always done is a challenge. Getting the word out that they can really use us, to think of us when they're having a challenge wasn't immediate. We started off sending out mailers and most of them hit the circular file. But word of mouth, over time, somebody who's used it, oh yeah, you should call, and then word of mouth to the next person is the most powerful within the practice community and the CME meetings like I mentioned before. Primary care providers, when the things they're calling us about are pretty complicated. 2/3 of what we hear about are what you'd call serious emotional disturbance patients. And we record, the different types of mental health problems and probable diagnoses, average about 3 per patient. So these are not the pure, simple ADHD, what medicine should I prescribe? This is ADHD, but the family is fighting and the kids bouncing from home to home, and then they got in trouble from school with suspension, and it's all the complex stuff. Most of the time, we end up doing this just with a phone call. I was a little surprised at how infrequently we ended up doing consult appointments, but in doing this over time, it's like, okay, yeah, I understand now why that's the case. That we're very commonly recommending psychosocial intervention services, so to work with a therapist in the community. The primary care provider may be willing, they're often calling about a script, and then we launch into the psychosocial intervention. They may not want to be on the hook for providing a script for something that is really out of their purview, and so we don't do a consult appointment because that essentially gives them recommendations of here's the things you could do. If they don't want to do that, we don't have a consult appointment. We say, no, defer that to the next provider. So there's a lot of back and forth in that decision of whether we do a consult appointment. We do it when it's going to be truly helpful to the primary care provider in delivering care and not derailing a family who thinks, oh, I'm going to see the psychiatrist, they're going to take over, but we're not going to take over care. We're just going to help the primary care provider to deliver the care. Most of the time, we recommend care remain with the primary care provider. Again, a little higher than I thought in getting into this, but that's frankly what we want the health system to do, is to help people get their care in primary care more often because the mental health system is strained. Care coordination, couldn't do without it. About half the time we have a question for Molly, say, can you help us find these things? We also do mandatory reviews, which I'll talk about in a second, and they are different populations, different scenarios. So there ends up being not a lot of overlap between elective and mandatory consults. I term this as a stitch in time. So if they've called us and we've directed good care, they're not likely to get into a situation where that's a very high dose or 5 or more psychotropics or the kinds of things that we do mandatory reviews for. We do a small virtual team, which base of at least a couple child psychiatrists and social work and admin time for essentially serving a state with 1.7 million children. It seems like crazy ratio numbers, but it actually works for how it's being utilized. And that we really like to have 2 people on minimum in order to be available on demand. If you only do this with one person, you have phone calls, you go to the bathroom, you eat, you're not going to be instantly available. Those that use it love it, but not everybody's using it. We get feedback from the people who use the service, and they send surveys back 25% of the time or so after their consults, and it's kind of boring because they say this is great, and they're telling us that their patient outcomes are improving. Those that don't call say things to me separately. It's like, I don't want to feel pressured to do something I'm not comfortable doing. Or I didn't think of it, or are you guys still doing that? Still just kind of missing the messaging. We very commonly recommend psychosocial services. 9 out of 10 calls on average, we're recommending a new psychosocial intervention. Most of the time when they're calling, they're saying, what do I prescribe? So this is a big part of what we do. And there was another little data study we were able to do with the state looking at foster kids and said, oh yeah, they were much more likely to be receiving psychotherapy after they had a PAL call than before. But we would expect that. They usually call because of medicine, 58% of the time. It's what drug do I prescribe, or what do I recommend and what do I prescribe? So it may not be the primary question. But that's 58% of it, that's the sole question they have, what med. We do recommend starting medicine, but we also recommend stopping medicine. So I think it's a fairly balanced approach. Elective consults don't solve the health system. It is a useful adjunct, but there are a lot more needs that it cannot solve. So just good to acknowledge that. Medication second opinion reviews we've been doing for a few years, and this was started out of a concern that mental health drugs are very costly. They're increasing in use quite significantly within the state, that there were unusual prescribing practices that we term outlier prescribing, and sometimes those outlier prescriptions were frankly medically unsafe for the kids. So Seattle Children's started working with the Medicaid division back in 2006, like a year before PAL got going, and eventually decided, yes, we will participate with the state to do some medication reviews for ADHD prescriptions only stimulants, and they were pretty wide ranges that were allowed. So if you don't know, Ritalin 120 milligrams a day is a really high dose. The highest FDA-approved dose for any age is 72 milligrams a day. So these were pretty generous limits that were put on, and still we had to do a lot of reviews. That started in 2006. We had some experience with that. About 3 years later, we worked with the state to add antipsychotics. And another 3 years later, we added polypharmacy reviews and reviews for a combination of 2 antipsychotics. AAP stands for atypical antipsychotic, sorry for the shorthand. And we started doing some reviews for the state of Wyoming back in 2007. That 2,000 reviews completed since 2006, it's significantly higher than 2,000 now. I didn't update that number, sorry. The system the state has, if you're a prescriber and you prescribe something for a Medicaid child, the script goes to the pharmacy. If it hits one of these flags of being too high a dose for too young a child or too many meds, there can be a flag that's then triggered to the healthcare authority. They contact the prescriber, say, did you really mean that, and why? Fill out this form and send a recent chart note so that you can tell us why this is appropriate for this child. And then healthcare authority looks at that and says, okay, we're gonna either just approve it on our own, or they're gonna ask their consultants to talk to the doc. And that's where we get involved, is then we talk to the prescriber to say, tell me more about this, what does this make sense, what's been tried, and we give care suggestions for where care might be improved. And ultimately, Medicaid makes an authorization decision about the medicine, about whether they continue to pay for something or why. So that's basically how the system works. For antipsychotics, there's a pop-off valve of child in crisis. The kid's having a rough time and it's getting stopped at the pharmacy. They're supposed to be able to get it regardless. To do mandatory med reviews, providers, if you do this on records only, you'd have to say no way more often than if you actually talk to the provider, because our records are usually not that great, honestly. If there is a flag that requires the medicine not be filled at the pharmacy, as rapid a process time as possible is very important, because providers can understandably be upset, say, my patient is suffering while they're not getting this medicine. Consistency is a big challenge. When the med review program started, there were actually 3 different institutions providing the reviews. It was called the Second Opinion Network. So Seattle Children's, Sacred Heart, and Marybridge were all participants in this and had their own consultants. There were persisting problems with different approaches and different processing times by the different facilities, and eventually the state said, that's it. This is not a good service if we're having all these different approaches. We need one approach. We learned that we need to be collaborative with the providers rather than just be, we're the approve versus deny folks. That if we're talking to the doc, what we really need to do is focused around best care of child. And how do we promote best care of child? What hasn't worked? What has worked? How do we help them do better? And oh, by the way, we also have to say something to the state about approval or denial. And we do audits to make sure that consistency happens. High-risk regimens, I was surprised how fiercely somebody could defend what they were prescribing when it just made no sense. So this is a lot of the art of doing these reviews, of getting good at that, and realizing that not everybody is going to be happy with you. When you do a mandatory review, you're automatically in a setup where some people are not going to be happy. Our old numbers were about 53% of the time people were saying this is really useful to the care of their patient, and a quarter of the time they said it's not useful for the care of my patient. Our numbers have continued to improve in these past few years. I didn't pull the more recent numbers. But there's always an element of people like, I hate the review process. Generally the message these days, I hate the review process of holding things up when it holds things up, but I really like the discussion with the reviewer, and we're talking about appropriate, helpful things for my patients. Just having a review system alone changes what people do. So we call that the Hawthorne effect, that when ADHD reviews were started in this state, there was a whole lot of prescription change that was going on. About half of those changes occurred prior to a review even happening. The provider got the notice, you're going to have to do a review, and they changed the script to then be within guidelines. So they just didn't want to hassle with this. So that's a fairly commonly noted thing. We also do this other unique thing for Wyoming, and this was a consultation need that they had that was kind of unique and kind of not. So by unique, they were having challenges with kids in their foster care system primarily, who were needing more in-depth evaluation and were unable to access it in any timely way. So kids who were going through a CHINS hearing process or mental health placement that involving courts were having these multidisciplinary teams and unable to get a child psychiatrist assessment in a timely way and having to make decisions without sort of a general gestalt impression. There were kids who were being placed in long-term facilities in order to get an assessment, which is not your ideal thing if they in fact don't really need to be there. So there were out-of-home placement concerns. State of Wyoming, depending on when you look, has either 6 to 8 child psychiatrists. They, as people come and go over time, they were, of course, first asked, could you help with this? And it's like, we are overwhelmed. We got way too much to do. And so we worked with them. We set up a process where the guardian ad litem or DFS caseworker could request one of these consults, and we rapidly set them up. The goal is within a couple of weeks. We set it up where we get information from the caseworker, we review the information from the caseworker, we talk to the caseworker, then we meet kid via televideo and talk to caregiver. And we create a report, and we try to set this all up to happen in basically a half day's time. So you get all the documents and the appointments all lined up. And so at the end of that half day's time, the consultant is creating a report that can be rapidly utilized by the court, by the DFS system, to say, okay, this is creating some new ideas of things that haven't been tried before. It's overall impressions. We give diagnoses and care recommendations. We are not, in those cases, working with a primary care provider. We're working with a system. And the system is about, okay, well, let's try to get a therapist to do this. Let's try to get a provider who can do that. It's a little bit different role. This was not easy to build acceptance. It was the Medicaid division that really wanted this, and some people within the foster care division that really wanted it, but not everybody, not all the frontline staff who were working in the foster care offices. So I actually went on a speaking tour. I went to every county in Wyoming and talked to all of the representatives of all the foster care offices with somebody from the state, and disavowed all the sort of presuppositions of what this would be, what this wouldn't be. And there was a lot of resistance initially, and over time it's like, oh yeah, actually we really like this, and we want more of that. We were finding kids had a lot of unrecognized problems, like anxiety disorders that were not, nobody said, oh yeah, you have an anxiety disorder that needs treatment. We're finding kids were really quite ill that are going through this process, not big surprise. Most of the time when people were making a referral to us, they were looking for an inpatient facility placement already. They were at that point. But much less of the time did that actually make clinical sense. If somebody has untreated anxiety disorder and maybe you should talk to a therapist and consider an SSRI, does that really have to be in an inpatient facility to do that? So it translated a lot more care in the community than was happening otherwise. And we did an evaluation to say, okay, if we made those recommendations, what happened next? So we worked with the state to say, okay, if we made that recommendation that was different than what the team was originally going to do, for the next year, what ended up happening with those kids? Did they end up in facilities anyway? Did they not? How did they do? And found that, yes, they did pretty well. I mentioned this before about the face-to-face tour. I didn't have another slide about this. So the positive outcomes, skip past this one. We did it, this was the analysis with the state of Wyoming, looking at basically everything we've been doing with them, because we didn't do anything in isolation. We did these multidisciplinary team foster care consults, we did mandatory medication reviews, and we did elective consults. And there were a lot of changes in their system in the course of those 2 years. Kids under age 5, their psychotropic use decreased by 42%. Doses greater than 150% of FDA max also decreased by 50% in the course of those 2 years, which is pretty unheard of to make such a dramatic change. So, and there was a fiscal return on investment for the state. So with everything, the costs all lumped in together, they figured it was nearly a 2-to-1 return on investment. So they're pleased with the outcome. And the providers, the DFS caseworkers, are very happy with this as well, and it's seen appropriately as we're encouraging use of local services. So what's going on in general? Why are all these? Why are ACOs and why is integrated care something that's being talked about so much? And you can see a number of different versions of this. This is just one slide that shows how expensive healthcare has become relative to what people earn in money. So the top 2 graphs are health insurance premiums and the proportion of contribution to those health insurance premiums versus earnings and inflation on the lower 2. So clearly this spread continuing indefinitely in 2 straight lines is not sustainable. And there's lots of different ways of looking at this as part of the health reform movement that's driving things, the ACO movement, and saying, well, we've got to do something that's better in a cheaper way somehow than what we have been doing. What we were doing with Wyoming is looking at taking off some of the highest cost problems, like unnecessary long-term psychiatric inpatient stays, and merging that more into outpatient services. That's a cost savings. Even more so is if you don't really need to see a child psychiatrist for your ongoing care, and you need to see your primary care provider with a little bit of advice, that's getting into more integrated care to deliver things in a little cheaper way. So to do integrated care, what would you need? You'd need some way to pick up problems a little bit earlier than, oh my gosh, it's a 4-alarm fire, because things are really costly at the point where kids have been suspended from school, parents are unable to work, everything's hit the fan. It's much better to do early detection, early intervention. So the principle of some form of screening is part of integrated care. You need a person who can coordinate care in some way, shape, or form. You need, because the primary care providers themselves are not going to be care coordinators for everything mental health and everything else they're doing. They need somebody else who can help them do that. They need some kind of ready access to consultation through curbside consults. Like our term for curbside is like what we do on our phone line. I just got this, I got a question for you, how am I going to handle this? Or formal, it takes an hour or hour and a half working with the patient, and you create a report and you send it to the doc. That's a bigger time investment, but both have value, and both are needed. You need some kind of referral plan for getting the right kids into this traditional, specialty mental health system that need it. And ideally, if you're doing a good job upstream, kids who don't really need it never end up having to go to specialty mental health services. So you're having the best use of that resource. And you need to be able to track and monitor. So if you're doing things as a health system to try to reduce the need for costly care and improve outcomes, you don't know you're succeeding unless you're tracking what's going on. So those are the general principles of integrated care. So you might have a primary care provider who says, oh, I got a kid who needs something. That's just step one. Maybe they did it through screening, or maybe they came in and said, I need something. They should be able to hand off to somebody who can kind of follow this through, help them get connected to the right kind of services, or help with diagnostic clarification or some other little step. If you had a child therapist in your office, ideal for the family. I mean, they can just see somebody there the next Tuesday. If not, some other relationship with you can get people in that need to get in quickly to have those early steps in care. It'd be nice to have a mental health prescriber who's good at what they're doing to consult with the primary care provider to make sure they're doing the best they can with what they're doing on that end, and available for consult appointments and some in the shared information system. There are lots of different versions of this happening. There's been so many studies done in adult medicine that basically the funding agencies said, stop, we're not going to study this anymore. It's a good thing. Our own mental health integration program, IMPACT program at the UW, is a big leader in this. There's been relatively few child studies in integrated care. DOCC in Pittsburgh, Intermountain Healthcare, there's just a few examples that have done this with kids. Integrated care research in kids is inherently a little less attractive to funders and to research agencies because kids overall, on average, are not as expensive as adults. Adults chew up a huge portion of the healthcare dollar, and most kids are relatively inexpensive, with a few isolated who are really expensive. When you implement a good integrated care system, you're giving everybody something more. So if somebody's getting no care and you give them a little bit of care, that tends to cost more than doing nothing at all. Whereas the cost savings of doing something in a stitch-in-time way comes from, they're in school, they have more productive adult lives because you did some good things early on in their life. The parent may be able to attend work, whereas before maybe they would have had to quit their job. As a health insurer, that's not your cost. Your cost is the healthcare cost. And so that's some of the reasons why child has lagged behind adults. We've been in discussions with the state to set something up in the Tri-Cities area. There's an expansion of our PAL program where we look to hire some mental health therapists in the Tri-Cities area that we could collaborate with and support and help and have them in a regionally shared way work with the primary care providers of their area to do more mental health services in a timely way. Again, not replacing traditional specialty mental health services, but serving that in-between stitch-in-time role, crisis management, first steps in care, getting diagnostic aids, and helping things move in the right direction. This is a slide from Anna Ratzliff, who's at the U, that what is effective in integrated care. You need something that's patient-centered and not just co-located, because so much co-location, I saw nodding heads when I said this earlier, is not really collaboration. It's just we're next to each other. Even shared electronic health records doesn't mean people actually look at the shared electronic health record. Both can do their own thing and still not communicate and not collaborate. You need something that's a registry to make sure people don't fall through the cracks. Again, I kind of mentioned this before. When you measure things, you can treat to target. So, yeah, I think they're getting better, but gee, their PHQ-9 scores went from 15 to 20. God, they're not getting better. What are we going to do to make a difference now, knowing that that this is not a situation where things are clearly better? And you have to make sure the treatments you deliver are evidence-based and evidence-grounded. And people are accountable for what they deliver. So that was running through a lot of different topics, and I was mostly wanting to get people thinking so we could have a conversation, just a few of us in the audience. So what kinds of things and thoughts has this been bringing up? Yeah. Yeah. So some of the principles, it's a great question. The question, I know I'm supposed to repeat questions, so the question was about what kind of recommendations do I have about which screening tools to use, which are most useful? A few rules of thumb. For a screening tool to be used regularly, particularly within primary care, it has to be short, has to be easily scored. It should be validated, because if it's, oh, I just made up this list, is not so great. So PSC 17 is one of my favorite general scales. Another one that's similar is called the Strengths and Difficulties Questionnaire, or SDQ, which is 25 items. The PSC 17 has the advantage of both a total score in 17 items and 3 different subscale scores, so internalizing, externalizing, and attention. So it gives you a bit of a clue. Not only is there something mental healthy going on, but where area that mental healthy problem might be in. And it correlates fairly well with a full CBCL, which is 100 questions and takes a computer to score. PSC 17s you can do just visually, bam, in the office. The advantage of the strength and difficulty questionnaire is they actually have some questions about what's going well, which a lot of rating scales don't ask about what's going well. But it's not as diagnostically, categorically helpful in the way that, internalizing, externalizing attention headers. If you had the time and had the staffing to do it, the longer scales, like the CBCL and the BASC, are well validated and give you a lot more detail about the likelihood of specific conditions being present. It's just not very practical in primary care to do such a thing. There's the disorder-specific scales. So things that we have in our care guide, for instance, again, free and validated, are the PHQ-9 and the SMFQ. Most people know the PHQ-9, but not everybody knows SMFQ. It's a short mood and feeling questionnaire by Angold. Also validated in kids. And the SMFQ, I think, is 7 items. Now, actually forgetting how many items there are, but it's pretty quick. There aren't well-validated free anxiety scales for kids. The one we have in our care guide is called the SCARED, which is a 41-item scale with all these different subscores of likelihood of different anxiety conditions, which I'll editorialize. For the primary care provider perspective, an anxiety disorder is an anxiety disorder. There's even research, the CAMS study, childhood anxiety medication strategy, I can't remember all the letters, but which was a big NIMH study that looked at anxiety in kids and tried to say what's the best treatment. CBT, cognitive behavior therapy, alone or with medication, medication alone or placebo. They had 4 study arms. They actually had 3 different anxiety disorders that they treated all the same. They were not a purist. They said generalized anxiety disorder, social phobia, and I can't remember the other one. But essentially with anxiety disorders, CBT and an SSRI. So it all kind of boils down to that with rare exceptions. There is the GAD-7 is valid, or 7-item generalized anxiety disorder scale. Is a lot of people use it for adolescents. There's not as much data in adolescents as there is for adults. It's a decent short screener. There's also a 5-item version of the SCARED that frankly nobody uses. It's essentially the most factor specific item from each of those 5 subscales within the SCARED, and just ask those questions. For ADHD, there's a bunch of them out there. We have the Vanderbilt ADHD rating scale in our care guide because, again, it's free and it has a few other areas on it. When you're looking for ADHD, what's the likelihood of an opposition defiant disorder or a depression anxiety disorder also being present, and gives you some clues about that. And there's other ones you can pay for. The practical challenge is a lot of practices are, well, free versus pay for, unless I have some reason to pay for something, Why would I? That's a really good question. We at PAL, we keep track when somebody calls us and says, okay, the PHQ-9 score was this, or this Vanderbilt was that. There's just another little box that we enter the rating scale if they reported that to us at the time of the call. We almost never heard that when we started the program. We regularly hear it now. Yeah, nobody in this, very few people in the state had heard of the SMFQ when we got started, and now it's pretty commonplace that people use that in addition to the PHQ-9. Advantage of the SMFQ is it's validated below age 13. PHQ-9 is only validated 13 up. So. No? Okay. Yeah, sure. It is uncommon for a primary care provider to have received mental health training. There's multiple reasons for that. One is that it's not emphasized in residency training. We've been working for years and trying to change that. Give you an example. Pediatricians have a 3-year residency. In the course of those 3 years, there's a required 1-month developmental behavioral pediatrics experience. Most of them take vacation during that month because it's not like the PICU where you can't leave. And so you get 3 weeks, in which case you really just focus on autism and developmental disabilities. And most of the time that's not where you learn much mental behavioral health otherwise. It's generally expected that you'll learn that in your continuity clinic, your half-day clinic a week that you have for 3 years. And that's luck of the draw of whether you happen to have a supervisor who knows this stuff or doesn't. So uniformly coming out of residency training programs, it's an area that's still lacking in pediatrics. Family medicine's a little more on board with mental health in general. You can't be an accredited mental health program without a psychologist or psychiatrist as another faculty member within the Department of Family Medicine, for instance. But family medicine has to cover so darn much. You got to cover all ages and all issues, and it's hard to be expert in child mental health in addition to everything else you have to be an expert in. So it's asking an awful lot. There are training programs that focus on teaching old dogs new tricks that you can pay for and go to a Psychopharm Institute course. I always am a little concerned about those courses if they are from the perspective of we're just going to talk about meds and what meds you prescribe and here's all the things you can use meds for. It's like, well, what about the rest? Sometimes that gets lost. Yeah. Mm-hmm. It was a big part of that decision. Yeah, I had been a general pediatrician at Kitsap Children's Clinic over in, my office was in Port Orchard, and did that for a few years. And then I had, my initial sense was, I'd like to do something different, but I'm not quite sure what yet. And I took a job as an ER doc and hospitalist and used my old NICU skills for a while. And then thought, you know, what's actually I'm most passionate about has been the mental health problems that I used to see and we're still seeing in those settings. I was in the ED and diagnosing a kid who came for some sort of behavioral crisis and said, you have OCD. You can solve this. Here's how, working with the family around that. And the other ED docs are like, what are you doing, man? It's like that. This is important. So yeah, I just decided I was going to be, I'm young enough, what the heck, I'll go ahead and focus on this with the idea that I wanted to do something with primary care and their needs for mental health help once I actually became a child psychiatrist. And it was sort of like, I'd like to do something. What exactly that is, I'm not sure yet, but I'd like to do something to help. Cool. Well, we'll end a little early. Thanks for coming.